Hello, and let's talk about syphilis. Syphilis, the question is not going to be on the board about the diagnosis because this is not step one, two, or even three. But usually there is few small tricks they're going to ask you about screening. If you suspected syphilis or neurosyphilis, what's the test you're going to use? If you already know that the screening test is positive, and how you're going to confirm this test? What's when you're going to suspect syphilis, when you have to screen for syphilis. So those questions you need to be aware of. So screening for syphilis is good to start with a VDRL or RPR. The RPR, if you use the titer and it's more than at least fourfold, more than 1 to 32, that's a very diagnostic to that disease. Um, Confirmation test, you can use treponema pallidum specific antibodies, FTAPs, or TPPA, or ELISA, or other of those tests for confirmation tests. And you need to understand also false positive tests. False positive tests with autoimmune disease, other spirochetes, or even in advanced age, you may see positive VDRL with very low titer. Neurosyphilis. You have to suspect neurosyphilis with any neurological symptom or sign where the patient especially had a history of a primary syphilis or was treated in the past for a syphilis. And in reality, it could be anything. They may present it with encephalitis, a delirium, kind of abnormal behavioral. But on the test, they'll try not to trick you that much about the diagnosis, and you may see the typical paresis. Means P for paralysis, A for Argyll-Robertson pupillary reflex, sensorium means hallucination, delirium, dementia, intelligence problems, calculation and judgment, and speech problem. If you see this mnemonic there, then that's your diagnosis for neurocephalus. Then what's next? You have to do the CSF and you have to understand how to read the CSF analysis. It may look like a viral with mildly elevated protein, but you will see pleocytes, and the cutoff is 20 for neurocephalus. And you have to test the CSF for VDRL or RPR and RPR for the titer. VDRL is more positive predictive value, and it can also help to follow with a titer for the disease activity. Not like the other test, even the specific antibodies, because they may positive or even false positive with an HIV infection, just an antibodies that pass through the CSF. So it's not more accurate, or the best to do is the VDRL, are those are more positive predictive value for the neurocephalus. And if you have it, you will start treatment. And for neurocephalus, you need to understand the treatment has to be IV penicillin. They're not going to ask you too deep questions about the treatment because they are know and they expect that you are not the infectious disease specialist, but they need you to understand it has to be IV penicillin, aqueous penicillin. Um, that's for the neurosyphilis and syphilis in general. Those are the most common questions. The other question, you will have a PCP, pneumocystic cardiac. A patient was admitted for suspected pneumonia, infection, cough, this and that. You treated for a COPD exacerbation. But this patient is, the key is he is immunocompromised and he is really rapidly deteriorating in the ICU. His AIA gradient very high, and if it's more than 35, it's an indication for steroid. CT scan of the chest may see multi-cystic lesions there, and those are with a thin wall. That's where is your key, thin wall multicystic. Then you start thinking about PCP. You need to understand also what's the treatment and what's the prophylaxis in a patient with immunocompromised or transplanted or HIV with a CD count less than 200. Then you need to know what's the prophylaxis. Prophylaxis is different than what's the treatment. In the treatment, you have the three options of IV trimethoprim sulfamethixazole, or IV pentamidine, or oral primaquine. with clindamycin. You need to know that, and that's also common in the questions. The other thing is skin lesion and skin abnormalities, and those ones also you need to be aware about. So in skin disease, you need to know Bemphigus vulgaris and to bullous bemphigoid. Bullous, it has a bulli, so it attends wall, and if it has a bulla there, you have to understand that it's a deep autoimmune disease. There is an IgG3 deposition in the subdermis. It's not in the epidermis, in the subdermis at the basement membrane level. In the Bemphigus vulgaris, it's an ulceration. It's also affecting the mucous membranes, and if a bulli has to happen, it will be rapidly, quickly ruptured, and you're not gonna see it. Even the patient's not gonna recall it, but you may see some small bulli there, and those will be very easily to destroy by Nikolsky test, or by just touching. Those bullis were ruptured easily. That's more is Bemphigus vulgaris. Treatment is steroid. Usually they're not gonna ask about the treatment. If you know and you make that image as a memory image, you just type on Google or anywhere Bemphigus vulgaris. Make yourself familiar with those images, and just, yeah, understand those are how it looks, and you can monitor those. If you go and you see that exact image in the ACP or in MKSAP, because very likely they're going to use the same photo for the test. The other one you need to know is drug reactions, all drug reactions, Steven Johnson syndrome, toxic epidermolysis necrolysis, bioderma gangrenosa, and bioderma nodosa, and uh, yes, bioderma gangrenosa. This is 10 with the gloving or the toxic epidermolysis. Also, again, you can find those are 10 versus Steven Johnson syndrome. You can find tons of those differential diagnoses. You need, if you understand the photo, that's all you need. Treatment, they're not gonna ask deeply about treatment. Usually, it's just the diagnosis and where is the what's the process. Or the other thing you need to understand is the drugs. Those drugs that are very susceptible for this kind of reaction will be anticonvulsant. Look for newly used anticonvulsant within days to weeks. Depakote, valproic acid, carbamazepine, alpurinol, or an antibiotics with beta-lactamase are more common in the test, and in reality they are more common. Dress syndrome, when there is usually there you will see also hypereosinophilia and neutropenia in that. uh, Leukocytoclastic vasculitis, again, this is an autoimmune, and you need to know the association with hepatitis C. So they will ask about the association. What's that viral infection, or the next antibody you're gonna test, or the test would be hepatitis C to look for association. You're gonna see a palpable purpura on the skin, hemorrhagic, red, bright red or dark red. uh, Bioderma gangrenosa, we said that it's very bioderma gangrenosa, it's very painful, non-healing ulcer that's not responding to the antibiotic. Then you're going to suspect the bioderma gangrenosa. Treatment steroid. um, they also like this question about screening and prevention, when to start screening, when to start the vaccination for flu, tetanus, herpes zoster. You may have at least one question or two questions. um, you need to understand also pneumococcal infection, and when to give the treatment for pneumococcal infection. uh, Pneumococcal vaccine, there is two vaccines there, but the easy way to understand is what's the age of your patient. Above 65, then you need one dose, and there is no booster. But if he's younger than 65, you need two doses. If the patient on risk with interstitial lung disease or structural lung disease or obesity or core pulmonale or other high risk patients, then they will need very likely the two vaccines to be given with a booster. Eye infection and red eye, also you need to understand that conjunctivitis, bacterial, there is a discharge, usually unilateral, but it could infect the other eye. Um, Use the local antibiotics. Make sure it's not orbital cellulitis that would require an imaging to the brain and to look for source of infection or deep infection and osteomyelitis. You need to understand episcleritis from scleritis, from conjunctivitis, viral conjunctivitis, or allergic conjunctivitis. Again, it's easy. You can Google the image or check them on ACP, MKSAP, or uh, MKSAP basics. So you can look to the images, understand, because if you know those photos will help you to save time on the test. You just click there and that's it. That's what I'm looking for. And yes, you got the diagnosis. You don't need to dig deep. Iritis, it's gonna affect the iris. You're gonna see some defect here with maybe hyphen or this and that, but it's very close to the pupil. Episcleritis only the palpebral and palpar conjunctiva, but it's it's not crossing the iris. The allergic cobblestones is there. Those are the differential. Ear infection. You have either herpes zoster with crust lesions there, crusty lesions affecting the ear, or you may have the otitis malignant in a diabetic patient. Um, Otitis externa malignant. You need to understand, of course, this is pseudomonas and infection, severe infection, painful to the ear, and the treatment will be antibiotics covering pseudomonas. And that's concluding most of our ID infection. It's this curriculum is not meant for you to cover the whole ID, but the most common questions on the board. And good luck. Have a good day.